Welcome, everyone, and thank you for joining the last webinar in Cystic Fibrosis Canada's virtual education series for patients and caregivers. The webinar today will be recorded for those who are unable to attend and will be available through our website for later viewing. Following the presentation, we will have a question and answer session. Please use the Raise Your Hand feature to be unmuted so that you can ask your question verbally, or alternatively, you can type your question in the Q&A box that's in the right-hand panel on your screen. We are very excited to have with us today Dr. Yves Berthiaume to discuss cystic fibrosis-related diabetes, also referred to as CFRD. Dr. Berthiaume is professor in the Department of Medicine at the University of Montreal. He is the director of the Cellular and Molecular Lung Biology Research Unit at the IRCM and is the recipient of the IRCM Gosselin-Lamar Chair in Clinical Research. His research interests focus on the role of lung epithelial cells in the pathophysiology of diseases such as cystic fibrosis and pulmonary edema. More recently, he has also explored the interaction of the inflammatory response with the development of CFRD. We are also fortunate to have Paul Underhill with us today to speak about his experience living with CFRD. Paul lives in Victoria, BC, and was diagnosed with CF as an infant. In 2007, Paul was diagnosed with CFRD and received a double lung transplant in 2011. He has served as past Western representative on CF Canada's Adult Committee. He is the co-founder of Rumble Drinks and appeared in Season 8 of The Dragon's Den, where all 5 dragons made an offer on his nutritional energy drink. Paul has degrees from the University of Victoria in psychology and law. He has a lifelong passion for all things health-related, is an active recreational and occasional competitive cyclist, and has twice participated in the Gear Up for CF bike ride from Vancouver to Banff. I'll now pass the presentation over to Dr. Berthiaume to start us off.
Hello, Joanna, did you hear me?
Yes, we can hear you, Yves.
Okay, good. So let's start. And I guess if I just press this, my slides are going to move, so which is fine. So just before we start, I'd just like to do the usual disclosure. As you can see here, we have support from the industry for different aspects of the work that we do, especially in clinical research. But I also want to point out that it's a bit unusual for a respirologist to talk about diabetes. So everyone will have to realize that I'm a pulmonologist who venture in the new world of diabetes. So let's start with a small case presentation, which was really my introduction of maybe to diabetes on a late Friday afternoon when a patient came to clinic. So we have this 22-year-old female, which is Delta F508 homozygous, and she has a bit of she's underweight, and more importantly, she's been losing weight for the past 3 months. Her FEV1 has been dropping also more steadily in the past 3 months, but when we question her or we examine her, we have no obvious sign of a pulmonary exacerbation. She's not known to have diabetes. She has no symptom of diabetes, and that's what you see here, what we call polyuria, which means having the impression that you need to urinate quite often, or polydipsia. There's a mistake here in the spelling, which means that you're always thirsty. And when we look at her fasting plasma glucose, it was relatively normal, and what we call glycated hemoglobin, which is sort of an hemoglobin that can be used to when we have a high level of glucose in circulation, the sugar will be attaching to the hemoglobin, and we can measure that. And in her case, it's in the normal value. So when we look at the clinical situation, the only thing that comes really that we're facing is losing weight and an FEV1 that is decreasing. So the real question is, could this clinical evolution potentially related to CFRD? And that's what I will try to demonstrate to you in the next half an hour, is that it is probably related to a CFRD. So in my presentation, I'm going to talk about the epidemiology of CFRD, how common is it, and does it have a real impact in the CF? We'll touch the pathophysiology succinctly. We could spend the whole hour talking about it, but I'll try to highlight the important point. We're going to address the issue, is CF-related diabetes just a variant of type 2 or type 1 diabetes? So type 2 diabetes is the one we associate with the patient who are obese, or that's what we call the metabolic syndrome. Type 1 diabetes is referring more to juvenile diabetes, or those who have diabetes diagnosed quite early. And could it be associated with lung function deterioration, and if yes, why? So let's review first the problems. So prevalence means, if we take a picture of the general population of CF patients, what are the probability that someone will suffer of a problem with glucose management? So what you have here, and I guess is in the red zone at the bottom here is what we call normal glucose tolerance. In the orange is what we would call glucose intolerance, and I'll define this. As we go up, it's CFRD without fasting hyperglycemia, and then we have CFRD with fasting hyperglycemia. These definition of glucose intolerance and CFRD is based on one test, and that's called the oral glucose tolerance test, OGTT. And what we do is we give you a good load of pure sugar, if you want, and we measure after 2 hours what is your glucose level in your blood. So if you're lower than 7.8, we say that you're normal. If you're between 7.8 and 11.1, we say that you're glucose intolerant. And if you are higher than 11.1, you have CF-related diabetes. But even if you have this, but in the morning we take your blood sugar and it's normal, then we say you have CFRD without fasting hyperglycemia. But if in the morning your blood glucose is higher than normal, then you have CFRD with fasting hyperglycemia. So as you can see at the bottom here, we have age. And you can see that there is a gradual increase of glucose abnormality, glucose metabolism abnormality as the patient grow older. As much as 77% of young adults have a problem with glucose metabolism, and close to 40% of adults higher than 30% have CF-related diabetes, either with or without fasting hyperglycemia. So this is really a significant problem to have glucose intolerance, and we'll talk a bit more in a few minutes of the consequence of it. But it's a very prevalent problem in CF, and we cannot blind ourselves and think that it doesn't exist. So if you see here, in fact, it's just, I guess, another view of the same thing. You see the percentage of patients with CFRD with age, and as we get close to 35 years and older, then you have 40% of the patients who are diabetic. So what's the impact of having this? And please don't look at this at the bottom here. Let's focus only on the picture here. And what we can see is that in black bar are patients with CF, and in white bar, CF with diabetes, and white bar is CF without diabetes. And you have the age group here at the on the axis, the x-axis. And as you can see, obviously, with ages, the mortality increase in CF, but the mortality in patient who has cystic fibrosis and CFRD is much higher. In fact, some people estimate to be 6 times higher than the mortality in CF without diabetes. So the first consequences of having diabetes in CF is a potential change in the mortality. Sorry, I just need to change this here. Oops. So what we just discussed, that CFRD is a common and important problem in CF. So why is it and why CF patients develop diabetes? So this is the test I was talking about a few minutes earlier, so the oral glucose tolerance test, and that's the plasma glucose that you measure here on the y-axis, and on the x-axis is time. And you have here the different group, so you have, again, after we give a sugar load to a patient who doesn't have cystic fibrosis, you see that the concentration of glucose increase quite rapidly after 30 minutes, and then it comes back down toward normal quite rapidly. If you have cystic fibrosis, in a group that we call normal glucose tolerance, as you can see, the glucose increase more than the control, but it goes back toward normal after 120 minutes, and that's why we say that it's normal glucose tolerance, because it's back to normal. But you can see here early on that the increase in glucose is much higher. And then you have those here who are glucose intolerant because the value is higher than the 7.8, but lower than the 11.1. And then you have those who have diabetes. So you can see a difference between the three groups. Really, it's the level of glucose elevation during the test. But what is more important is this slide. So instead of having here on the y-axis the glucose, we measure now the insulin level. And again, in the same group, the control, the glucose intolerant, the normal glucose, the CF patient with normal glucose tolerance, the CF patient with intolerance to glucose, and patient with CFRD are here at the bottom. So what you see here is if you're controlled, quite rapidly, after 30 minutes, your insulin level goes up quite rapidly, and then it comes back down gradually after 120 minutes. Now, for CF patients, no matter if you're normal glucose tolerant, glucose intolerant, or diabetic, you can see that this first phase of insulin secretion is blunted. It doesn't exist. And that's the reason why you have this higher increase in glucose in these patients compared to the patient without CF. Now, what's interesting is look here at this blue line, which is patients which have glucose intolerance, and their insulin level after 120 minutes is higher than the control. And that's why some of the CF patients, early on, before they get diabetic, one of the most frequent symptoms are symptoms of hypoglycemia, because the blood glucose is not only controlled by the insulin, but there's also glucagon and other hormones involved. And as your blood sugar comes down, if your insulin levels stay high, then you're more at risk of developing hypoglycemia. And as I said, it's sometimes an early sign that the patient is moving toward a more serious problem with the sugar control. So, in fact, if we look at the data differently, and you look here at the, another way of looking at it is the amount of insulin secreted. It's the area under the curve in a very special test. And as we can see here in CF compared to control, again, the amount of insulin secreted in what we call the first phase of insulin secretion is much lower. So this is already telling us that one of the biggest problems with cystic fibrosis is the fact that the pancreas, and mainly the islet, the beta cell islet in the pancreas, are not responding normally to an increase in glucose if the glucose goes up in your blood. And the main reason for this, although it's not very well known, this is data obtained from work that we did with Dr. Vincent Poitou, which is an expert in CF, in beta cell function in general in diabetes, and those are coming from CF mice. And you can see here that the beta cell mass, and the beta cell are the cells which are producing the insulin. And if you compare here CF mice on the right side versus a mice that doesn't have a cystic fibrosis, you can see and the pink here is the beta cell. You can see that there's a significant decrease in the number of beta cells. So one of the major problem associated with CFRD is the secretion of insulin, which is decreased, and also probably this is in part secondary to a decrease in the number of beta cells in the pancreas of a CF patient. So if we compare the CFRD to type 1 diabetes and type 2 diabetes, and we look here at not the prevalence because it's like comparing apple and oranges, but if we look at obviously it starts to appear in the young adult as we've seen, whereas type 1 diabetes most likely will appear in the childhood when you become an adolescent, a teenager, and then mid to late adulthood with type 2 diabetes, as we say, it's really related to healthy or unhealthy style habit. Normally, we say type 2 diabetes is associated with obesity, which is not the case with type 1 diabetes. And in CF, it's associated to normal or underweight, as in the example I've shown to you. And the major difference is, as you can see, is in CF, we have a severe decrease in the insulin, but it's not complete compared to type 1 diabetes, and it's a lot more variable in type 2 diabetes. So the question is, if there is a decrease in insulin, why does it take so much time for becoming obvious that the patient has diabetes? And this is still a question of a lot of debate between scientists right now, but we think that it's insulin resistance that is changing with age, and that makes the lack of insulin becoming is a more important limiting factor when you become resistant to insulin. So I'm just going to... We have tackled the question that CF is characterized by hyperglycemia, even in the patients who are considered to be glucose tolerant. And the key factor, as I said, and I'm repeating myself, is a reduced insulin secretion. So the question then is, what's the relationship to lung disease? So this is a relatively old paper, as you can see, 1992. But it's quite interesting to see that it's a study of 38 patients who developed diabetes versus 38 CF patients who did not develop diabetes. And you have here the body weight and the pulmonary function on the right panel. And as you can see here, the control patient would have remained here, and the FEV, the weight is dropping way before we can make a diagnosis of diabetes. And the same thing for the pulmonary function. They are decreasing way before we make the diagnosis. And the question is, as we heard a bit earlier, the diagnosis is based on a very specific test. You need to have a value of the OGTT over 11.1 for us to say that you're diabetic, or having a abnormal fasting glucose level. However, what I didn't tell you is that if we look at people who are normal tolerant or glucose intolerant, it's the fluctuation of glucose during the daytime that is very important. So after each meal, the glucose goes much higher in a CF patient than in a non-CF patient. And it's believed that it is these glucose fluctuation, large flux of glucose, that might influence the inflammation. Another way of looking at this, that was a prospective study looking at FEV1 decline, so the percentage decrease of FEV1 every year in CF patients. And let's look only at the square here, which is the FEV1. And the square show that if you're glucose intolerant, your decline of FEV1 is higher, is more important. And if you have a cystic fibrosis-related diabetes, it's even higher. So it's very important that to realize that the presence of a glucose abnormality, or glucose metabolism abnormality, I should say, has a repercussion on CF lung disease. Now, this is a very complicated slide, and but I just want to use it to tell you that glucose is the basic fuel, if you want, for our cell, and it's true also for the cell lying in the lung. So here, what you have are the epithelial cell in the lung, and this is the glucose that is used for the metabolism of the cell. But what also important is we have different proteins that are involved in moving glucose around in cells. And what's happening when you have a high level of glucose in the blood is the glucose goes inside the cell, but it also goes outside the cell into the lining fluid. So what's happening is that the high glucose that you have in your blood ended up as high glucose in the lung. And I'm just going to skip this slide to what's the impact of having a high glucose in the airway. And what you see here is an experiment that was done by the group of Dr. Baines in London, which is one of the few persons who has tackled this issue. And what you have here is the growth of bacteria, mainly Pseudomonas, in the airway surface fluid, which means the cells were in culture, and they put Pseudomonas on the cell surface, and then they put at the bottom of the cell different concentration of glucose. And here you have a normal concentration of glucose. Here it was increased to 15, and here they've put 5, and the 10 here is a glucose that doesn't get metabolized in our body, and it's not used normally by cells. So what you see here is when you have higher glucose put at the bottom of the cell, the bacteria grow faster. And it's even more important here, it was done with CF cells, and you can see a very large growth of Pseudomonas. So the message here is that when the glucose is high in your serum, then it goes high in your lung, and this helps the bacteria to grow faster, so you have more bacteria. So how often does the glucose level get high in CF patients? So here it's another study that was done in 2007 by the same group. And what you have here is the proportion of the day where the blood glucose was higher than 8 millimolar per liter. And you see here in the healthy volunteer, very low. In CF patient with normal glucose tolerance, not too bad. But if you have CFRD, you can see that 60% of the time, you have a glucose concentration in the lung higher than 8, which will promote the growth of bacteria. So this has a very significant impact on the response of your body when you have a high glucose in the blood. So let's get back to the day-to-day activity, which is how do we screen for this? So I spoke to you a bit earlier about we can use what we call glycated hemoglobin, and that's how it's called, A1C. The problem is in CF, it's been shown to be relatively, well, I shouldn't say, the sensitivity is not at the best, and there's a lot of false negative. This is another indices that can be used. Again, as I said, it's not very sensitive in CF. Fasting plasma glucose has shown you that there's a lot of patients who have very abnormal glucose metabolism but still have normal glucose level in the morning. Your glucose, when it's high in your blood, goes out in your urine, but it's not very sensitive in CF. And one of the promising avenue is what we call continuous glucose monitoring. And I'll show you in the next slide. So that's why presently the best test is still to do annually. It's a bit challenging to do that, but I would say every 18 months to 2 years we should repeat the test. More frequently if we have a reason to believe that something happened. So it's the oral glucose tolerance test that remains, as we speak, the gold standard to define the presence or not of diabetes. This is what I was talking about, the continuous glucose monitoring for screening. And you can see here, this is a small capsule that is put under the skin. So, and you keep it for in fact, it could be up to 3 days. And we can measure the level of glucose I think it's every 5 minutes, if I'm not mistaken. And we get a picture of what's happening to your blood glucose over time. And you can see here that in CF patient with a normal glucose tolerance, the fluctuation were not too bad. But look here at this patient who has diabetes. His blood glucose is going all over the place. And that's why we think that a very sensitive technique might help us to catch people a lot earlier, which, you remember the slide when we make the diagnosis too late, maybe using this, we would be able to catch people much earlier. Now, Dr. Rabaza, with whom I work on a regular basis, is talking to me that there's a new technology that is even more simpler to use. It's more like a patch that you put on your shoulder, and then just with an apparatus like an iPhone or a cell phone, you can just pass in front of this, and then it would record all the information that is in the patch. So maybe there's another simpler way that is coming in the near future. So once we find something, what do we do? And so this is really the important part. The OGTT. So as I said here, we have an OGTT that shows abnormal glucose tolerance versus, but the fasting glucose is normal. So the question, how do we treat a patient like this? When she doesn't eat or have a high load of sugar, her blood glucose is normal. So the first step, as far as we're concerned, is nutritional counseling. And we have to be very careful to avoid weight loss in CF. So we're not talking the same type of counseling that we give for type 2 diabetes. It's very important to make good choice of the type of glucose that you're eating. Obviously, eating an apple versus a piece of chocolate cake, it's not the same type of sugar, and the one has a lot more repercussion on the rapid increase of your glucose versus the other. Repartition, Repartition would mean that it's try to avoid this huge load of glucose suddenly. So if you're going to eat a piece of cake, take it a small piece and maybe take the rest a bit later. And also eat proteins before you take your glucose to slow down the glucose absorption. The real big question is, when should we start insulin? And really, as we speak right now, this is still a big debate for people treating diabetes in CF. And it's really probably you would get as many different answers if you speak to different endocrinologists. There's not a huge place for oral agents at the moment, at least from our point of view in our clinic in Montreal, but I know that other clinics might view this a different way. So why thinking of insulin? Well, the best study that was done by Dr. Antoinette Morin many years ago shows that when you start insulin, the major impact is really a change in the body weight. And we think that what's happening is really when you have CFRD, which are the blue column here, you can see that the protein breakdown is increased and the net synthesis decrease. And that's probably why people start losing weight. And when you start insulin, you stop this protein breakdown, and so they can increase their weight. So really the main reason to start insulin, we think, when the patient doesn't have fasting hyperglycemia, is if you have a body weight that is decreasing and you want to control that decrease in body weight. So what are our recommendations for starting insulin? So as you can see here, where really we start thinking of giving insulin more when the people have a glucose intolerance, and as we get closer to have a real CFRD, then insulin is really the choice of therapy. And in fact, as I said, the insulin will prevent the decrease in the weight, improve lung function, and probably decrease the rate of recurrence of infection. Is this the only way of doing it? No, and I just want to show you a project that was done in our clinic by Nadia Baudouin, who's a kinesiologist, where we try to use exercise as an adjunct, or I would say as a preventive therapy before trying to use insulin. And what we did is we took a CF patient who were either glucose intolerant, CFRD newly diagnosed, and I won't explain, but this is another category. And these patients had no treatment, no medical treatment for their glucose intolerance. So no insulin, no hypoglycemic agent. They were just freshly diagnosed. And we submitted them to a protocol. A group of patients went for exercise, and the other one was just follow and make recommendation regarding exercise program. I'm sorry this doesn't come out very well, but you have here the control group, and here you have the exercise group. And this is the OGTT, again, done in the two group of patients, pre-exercise or post-exercise. And you can see here that in the group who was involved in an exercise program, we had a significant decrease of the glucose in their blood after 2 hours in the OGTT. In fact, you can see that overall the curve is at each point there is a decrease in glucose. So these patients, when decreased their glucose after 2 hours of 2 millimolar, which is a significant increase. And this was done just with an exercise program, a structured exercise program, adapted for each patient, with close follow-up with the kinesiologist who would phone call the patient, and they came back only once in the 3 months to reevaluate their program and see how they were doing. So just exercise prevented significantly or improved the glucose tolerance in patients. So in conclusion, CFRD has a significant impact on CF disease evolution. The main problem is insulin deficiency, and we think that as we age, that's why there is more and more glucose abnormalities, because insulin resistance is sort of creeping on. It probably has a pro-inflammatory rate. It has a catabolic state, which has an impact on protein and lipid metabolism. It has an impact on the lung. And the best screening approach, as we speak, remains the OGTT. We hope to be able to have a better test in the future. It's clearly an additional burden. And insulin remains, I would say, the optimal therapy, but we still don't know who should be, how, and when to start. And I think I should have added here, trying to modulate the nutritional habit, increasing exercise are also key factors that will help in control this. So on this, I would end my presentation, and I guess get the floor back to Joanna to keep the conversation going.
Thank you, Yves. We're going to pass it over to Paul Underhill now to hear about his experiences living with CFRD.
Great. Yeah, thanks, Joanne, and thank you, Dr. Vachon. That was a fantastic presentation, and I'm sure it's going to raise some great questions from the participants, and I might have a few myself, but an excellent overview of the situation, and I'm really glad to have you had to give that. What I hope to offer the people listening in today is just a little bit of experience of what it's like to live with CFRD and provide a patient's perspective on some of the points that you've just made. So just a little bit about me. We've heard of course, I was born with CF. That's, Delta 508 times 2. And I had a pretty healthy childhood before getting much sicker in my 20s. And where it really hit me hard, both the diabetes and CF, was in my 30s. And I don't know, I mean, I heard about CFRD. I didn't think it necessarily applied to me. I felt pretty good that way. And as you've seen, the tests can come back again and again showing that you're normal. So the testing that you get isn't always the best indicator. And I think we really have to learn as patients to tune in. And it's one thing to read those symptoms, but when you look over the, weight loss, exacerbations, general feeling of unwellness, that sounds very familiar because we experience that so frequently with a pulmonary exacerbation whenever we get down. So for me, it really showed up on a road trip I had done where I was just feeling worse than normal, and I couldn't quite put my finger on what it was. And I'd actually gone down to Mexico, and I had to drive back up north, and I was feeling so poorly, and it didn't feel like a regular infection. That should have been my first clue. Second thing was my own self-test, absence of labs, being on vacation, not able to go and get my blood sugar tested. I actually went into an In-N-Out fast food joint and got a meal with medium root beer, and thought, well, if this is anything to do with the diabetes, maybe I'll know by sort of trying to eat, because I was also losing a bit of weight and not feeling well. Suffice it to say that eating fast food, including fountain pop, not a good idea. And the impact it had on me as an individual, I just felt incredibly sluggish afterwards. I could barely move. I could barely even walk one floor up to the hotel room afterwards. And, the lungs were not in great shape, but I felt like it wasn't the lungs. And sure enough, when I got home from that trip, I did get diagnosed with diabetes. So, it's just sort of a silly reminder maybe, and not a very scientific thing, but in order to experience it, if you're feeling down, if you're feeling weak, these are things to, obviously tell your patients to look out for. If you're a healthcare provider, as a patient, something to really think about is there's a slightly qualitatively different feeling. And And then to the idea that Dr. Bertillon was speaking about, like when do you treat and how effective is it? I think at the time, I've been just barely passing those fasting blood sugar tests. And when I got back, actually, I did manage to fail it, I think, which was a reason for beginning treatment. And I was warned, it can be quite a burden, and it's such a challenge because people with CF already have so much going on. But I actually wanted to share my experience that I actually didn't find it that big of a burden. They give you the insulin, little system, and yeah, you've got to, apparently calculate how much you need each day. But really, after a couple of weeks, you get the hang of it, and it's really about getting dialed into your own body and how you react. And the main impact is you start feeling better, and it's easier to keep weight, and it's easier to be stronger, and your lung function, at least in my case, my lung function went up. So it sounds, you might think, you get a diagnosis, or if you're dealing with patients, your patient gets a diagnosis, that's hard. It can actually be looked at as kind of like a good news, because things have generally been a bit off, and now you've got something to treat and a reason to feel better, and very often you'll feel better when started. I certainly did. The one caution that I had from a few sort of insider tips that they didn't sort of give me at the diabetes clinic or CF clinic when I got diagnosed. One of them was really practical. The needle tips, the big routine of cleaning everything, your hand, which is very important, of course, to have good hand hygiene, but like washing everything with alcohol, selecting the needle tips. One thing I learned from a friend who had diabetes was he never used the alcohol. He always cleaned his hands, but he never used the alcohol. And I'll admit that since I talked to him, and that was back in 2010, I haven't used an alcohol wipe a single time to inject it. Not recommending that. I'm just saying that for some people that find that they're out and they're trying to gauge the risk of whether to inject or to not, and they have missed their alcohol pad, that it might be worth getting that insulin in you. Another factor that really made it a lot easier was the short length of the needles. The default can be 6 or 8 mils. I've actually opted for a 4 millimeter needle that works perfectly, and it's essentially painless 90% of the time. So that really eases the burden, having the right size needle tip. Small practical point there. And another really important point that was already made in the presentation, but it's something I want to follow up on, is that idea of so that you have to calculate your insulin based on the usually the number of grams of carbohydrate and what you're eating, and that can get intimidating. It can get often mathematical, and even if that's the case and that's what you're using, you're still going to have to do trial and error with your blood sugar machine afterwards to gauge how that's impacting you. What I found instead is you get your regular meals, and after using that system for a week or two, you can really eyeball it, and you really have to take into consideration the amount of protein, fat, and fiber. Like if it has more protein and more fat and fiber in it, then it's going to absorb slower, and you're going to need less insulin, and that's massive. So per the point about apple versus chocolate cake, I'd actually written down in my notes here, it's the same idea of fountain pop, which I can never do that, or straight juice. I just don't drink those things anymore. I always try to opt for the more balanced, meals, and it's a little bit of homework, but it's also pays big dividends. So as I say, I'll probably make this point a couple of times, getting diagnosed with CFRD can be perceived sometimes as a negative, but when we focus more on the on treating it, we find our overall health can increase. And even prior to transplant, I did find it made an impact. Just looking at my notes here, a couple of things I want to share this idea too that we've hit it at is whether or not you're a person who really needs to gain weight or watch your weight, or whether it's the case where you have to be more normal. The more normal someone's weight is with CF, the more normal a patient has, in terms of the weight, then the more focus we can have on sort of eating, quote, properly, like really trying to focus in on healthier foods, which has a real positive impact on blood sugar, which in turn, as we've learned, due to the link between the pathogens in the lungs and blood sugar levels, can impact our health really positively. So all of that to say, what I was told at the time, eat basically all you want, don't worry about it. This idea of repatriation or trying to moderate the intake of simple carbs wasn't something that was really taught to me. I had to learn that myself, is try to avoid, the junk food and the binges of simple sugars, because that really does impact not only how you feel, but also how your lungs do. So yeah, fast forwarding to now, I can safely say that, it's managed easily. I find it pretty unobtrusive in my day. When I go out, I have to bring the pen with me, but it's really not too difficult. And I think a key reason for that is something I alluded to in the introduction there, is the fact that I do try to do quite a bit of exercise, fully understanding that many CF patients aren't able to exercise at the same amount that I do. But I cannot emphasize enough just how, if we are able to move, and most of us, of course, do have the ability to do some kind of exercise, how dramatic an impact it does have on the blood sugar levels and on well-being. So you saw on the chart of Dr. Bethion the study, which shows you the drop of 2 millimoles. And I can tell you from personal experience, on the days when I'm going to go riding, I don't even take the insulin in the morning. If I take even a couple of units, I'll go hypo. And I take that as a good sign, because when I don't take the insulin and exercise, the effect lasts for many, many, many hours after exercise. And of course, this is well understood in type 2 diabetes. I think it's maybe not as well documented in CFRD, but it seems to me it's an even greater effect. Like, it's the effect of exercise in and of itself is massive. So because our lungs get better when we exercise, because we feel better when we exercise if we can, and then also because it's so good for CFRD, obviously, exercise, in my opinion, from my experience, is like the number one adjunct treatment for CFRD. So I've sort of given a lot of information there as a patient living with it, but the overall impact and what I'm trying to communicate is, A, it can be a good thing to get diagnosed because you're treating a problem. B, it doesn't have to be too much of a burden after you get it. And C, in order to help limit the amount of insulin that you need and help moderate exercise is, from my personal perspective, the easiest and best choice to help control it. So with that, I'll turn to you, Joanne, and I'm sure there's questions for Dr. Bethion.
Excellent. Thank you so much, Paul. Those were great presentations, and we do have time for questions now. And I'll just mention again, you can either type your questions in the Q&A box, or you can use the raise your hand feature, and I can unmute you so you can ask your questions. And we actually do have a couple of questions already here, so I'll start with them. The first is, could secretagogues, and I'm not sure if I'm saying this correctly, be effective to stimulate the pancreas's production of insulin? I believe that's for Eve.
So, yeah, that's an interesting question. There's a lot of as I told you at the beginning, I'm not an endocrinologist, but as far as I know, from the hypoglycemic agent, there is a class of them that are directed to stimulate not as much the production, but the release of insulin. And as far as we know right now, they are not necessarily that helpful in CF, probably because the beta mass is low. So it's really more the mass of beta cells that are a limitation. There's another type of drug that are a lot newer. They are called the incretin, and they are sort of an hormone released by the stomach that also influence insulin. But up to now, the results are not that conclusive. So I don't think there is an effective way at the moment to stimulate the release of insulin by the pancreas. Well, I mean, there is, but it doesn't really help in CF, I should say.
And a follow-up question from the same individual is referring to the OGTT that's recommended annually. They're curious if there is an age that it should be started.
So, I didn't remember. So since I saw the question, I cheated, and I went to see the clinical care guidelines for CFRD that have been published by Dr. Antoinette Morin in 2010, in fact. And the recommended age in these guidelines is 10 years old to start the OGTT. In fact, if you want, Joanna, I can send you, I think it's easily accessible, but if you people want to look at it, it was guidelines supported by the Cystic Fibrosis Foundation in the U.S. So.
Sure, that would be great. Thank you.
And I think there is another question on the impact. How do we decide whether to start insulin?
There is another question here, too, on when you get CFRD, does it remain with you forever? Is there any way that it can be reversed or perhaps prevent it from getting worse?
I'm sorry, yes. So that's a very interesting question. We've been, Dr. Rabaza, with whom we're working at the clinic, we've been doing the OGTT as a research project, and so we have a prospective cohort of about 280 somehow patients who've been through the test, and more than once. And if you have CFRD without fasting hyperglycemia, and you apply some of the good healthy habit that Paul has developed regarding how to eat, doing exercise, you could go back to become only intolerant, that's for sure. I think the point of no return is when you start to have a real fasting hyperglycemia. I think when you reach that state, it's probably a bit more unlikely that it will be able to reverse. But all the others, you can move around these from one test to the other. And this is very important that when we do the test, because it's so sensitive, for example, if you just had a cold or a respiratory infection a week or two before you do the test, it may be better to postpone the test, or for sure if it's in the same week. So, because infection will change your glucose tolerance. So, the answer to the question is yes, you can reverse, but mainly when the abnormality is only in the OGTT. When you start to have fasting hyperglycemia, the likelihood to go back, it's a bit less unlikely. It's more unlikely.
And that's great to know. And if I could add to that from my personal perspective, I forgot to share that prior to transplant, I was taking 4 to 9 units of insulin, and post-transplant, the suggestion sometimes is it can be worse with the additional corticosteroids. And but I've actually found now I'm taking between 2 and 4 units most of the time, and I have contrary to popular belief, I don't have the healthiest diet. I eat pretty good, but when I actually make a point to eat well, I need 0 insulin. So, yeah, in my personal experience, it can be reversible.
Excellent. Another question that came in is, can you explain again why some patients have low blood sugars before high blood sugars?
Yes. So, can you go back to my slide?
Yes.
Is it possible?
Mm-hmm.
And I'll try to, if you let me go forward with them.
You should be able to.
Should. It doesn't move right now. Let me. Oh, I see. I'm going in the wrong way. That not helpful, right? So we're just going to go back to one of the earlier slide here. Here we go. So if you look here at the green line, and this is the plasma glucose. You see that after 120 minutes, the plasma glucose is sort of coming down, okay? Or it will be easier if I will cheat a bit here. Let's assume, because as you can see here, there's error bar, so it means that that's the mean, but let's assume that after 2 hours, the blood sugar is around, just barely around 8, okay? And then look at the insulin. The insulin in the same group of patients is still going up. So as your blood sugar is coming down, your insulin level is still high. And the reason is that, as I said, there's other hormones that control the glucose in your blood. For example, glucagon, when it's released, will increase your blood glucose, but there's other hormones that will be involved. So here, your blood sugar is coming down, but your insulin level is still high, so it will decrease even further your blood glucose. And as it decreases below, the normal, then you will feel hypoglycemic. So it's sort of like if your pancreas is too lazy and it secretes insulin too late. So when you start to have less need for insulin, now it's putting out insulin, which then decreases even furthermore your glucose. So that's why very often the patient will have, especially if you take a high sugar load, you will have this sensation that at some point you might become hypoglycemic. Not at the time you take the sugar, but a few hours later. I hope this is clarify a bit
Thank you, Yves. We have time for a couple more questions, and there's a few here. The first is, a number of non-invasive glucose monitoring devices are under development using near-infrared illumination and other technologies. Is there any reason to think that such devices might not work with CFRD?
The real answer to this is I cannot provide a good answer. I'm not good enough. I don't know these technology well enough to give you a good comment, but there's no particular reason, in CFRD, beside the pathophysiology, the measurement of glucose is in no way different than it is with any of the other type of diabetes. So if these instruments have been accepted for use for treatment of, for monitoring diabetes in general, then there's no reason why they wouldn't work in CF.
Okay. And if you were to stop the insulin to see if the CFRD was under control, would you repeat the OGTT?
So the question is, if you're really using insulin because you have fasting hyperglycemia, then I think the best thing is to see how your blood sugar in general would evolve, which means by measuring your glucose on a regular basis. The OGTT is really, it's not a monitoring of the evolution of your diabetes, but it's for the diagnosis. So really, if someone has decided that you need insulin, it probably means that your diabetes is either you were losing weight and you were, even if you were just glucose intolerant, and then they use a long-acting insulin to make sure that your catabolism is lower, or it's because you had very high level of glucose in general, and then it's more important to monitor how your glucose varied during the daytime than repeating the OGTT.
Okay. And then the last question that we have here is the idea of insulin stacking scientifically proven? I have been advised to refrain from taking rapid-acting insulin within 4 hours of a previous dose. However, I know type 1 diabetics that don't follow this rule. and they're interested in your thoughts on that.
Well, this is beyond my clinical expertise. That I would need to redirect this question to Dr. Rabaza, the endocrinologist in our clinic. I wouldn't be able to really answer this properly. But if you want, I can ask him.
That would be fantastic. So for the person that asked that, we can have it answered, and I can relay that answer to you. And then the last thing was whether we can have access to your slides and post them. Eve, they're asking for them as well.
Yeah, no problem.
Excellent.
You have them, right?
Yes. So I can post them up.
Yeah.
Excellent. Well, that's all the time that we have today for the webinar. If you do have any other questions, though, you can submit them to me, and I can send them to either Paul or Eve to get answers for you. We'd like to send a big thank you to you all for joining us, and to Dr. Bertiome and Paul for their informative discussions on CFRD. So thank you to you both.
Thank you.
Thanks, everyone. Bye.
Bye.